thorax, mechanism of respiration, and interchondral joints. So in this we discuss the competencies, that is articular surfaces, movements of manubriosternal, costovertebral, costotransverse and Xiphisternal joints. So that is the sternum, showing manubriosternal joint between manubrium and the body of sternum. Manubriosternal joint, it is a secondary cartilaginous joint between the manubrium and the body of sternum. Articular surfaces are covered by hyaline cartilage. There is an intervening disc of fibrocartilage. So that is the binding material. It may ossify later in life, but bones do not fuse. This is for the necessity of respiratory movements. Costovertebral joints of the heads of the ribs. A typical rib, that is 3 to 10, possesses two articular facets, sloping away from each other and separated by ridge or the crest of the head of the rib. Each facet forms a small synovial joint with a demifacet of the vertebral body. The lower facet articulates with the upper costal demifacets of its own vertebra. The lower facet articulates with the upper costal demifacets of its own vertebra. Lower rib facet articulates with the lower costal demifacet of the rib vertebra above. Lower rib facet articulates with lower costal demifacet of the vertebra above. An intra-articular ligament attaches the ridge between the two costal heads to the intervertebral disc. Capsule is attached around the articular margins. It is strengthened in front by tie radiate ligament that has 3 bands. The upper band passes across the joint to the body of the vertebra above. Lower band passes across the joint to the body of vertebra below, that is its own vertebra. The central band runs horizontally deep to the anterior longitudinal ligament and cross the intervertebral disc, with which it blends to join with the fibers of the same ligament on the other side. This arrangement of central band is called as hypocaudal bow. Costovertebral, that is joints of the heads of the ribs. The first rib articulates only with T1 vertebra. Therefore, this vertebra possesses only one facet, and the radiate ligament has only 2 bands instead of 3. Now we go to costotransverse, joints of the tubercles of the rib with the transverse process of its own vertebra. The tubercle of the typical rib possesses 2 facets, one medial and other lateral. Medial facet is articular. It articulates with a facet near the tip of the transverse process of its own vertebra. Lateral facet is non-articular and gives attachment to one of the ligaments of the joint. 3 ligaments reinforce and help to stabilize the joint. Then Xiphisternal joint. It is another secondary cartilaginous joint between the body of the sternum and xiphoid process. It commonly starts ossifying after the middle age. Then we go to describe the mechanics of the types of respiration. Inhalation of respiration is initiated by the contraction of the diaphragm. It descends about 1 centimeter during normal breathing and up to 10 centimeters on forced breathing. Its contraction causes the muscles of the thorax to pull the anterior ends of each rib up and outwards, enlarging the volume. As a result, pressure inside the thorax, intrathoracic pressure, and inside the lungs, intrapulmonary pressure decrease relative to the outside atmospheric air pressure. During exhalation, the lungs and the chest will return to its equilibrium position and shape. Thoracic cavity volume is reduced and the pressure builds up to release the air from the lungs. In quiet breathing, only elastic recoil of the lungs and chest walls is needed to return the thorax to equilibrium. That is a passive process. However, a forceful expiration, additional muscles, that is intercostals, in the thorax and abdomen are also used to further increase the pressure. Types of breathing. There are two main types of breathing, chest breathing and abdominal breathing or diaphragmatic breathing. Chest breathing. This type of breathing is characterized by upward and outward movement of chest and is found most commonly during vigorous exercise and emergency situations. Abdominal or diaphragmatic breathing. When we breathe, the diaphragm tightens, flattens and moves down. As the diaphragm moves down, it pushes the abdominal contents down, which forces the abdominal wall out. When we breathe out, diaphragm relaxes, air passes out to the lungs and the abdominal wall flattens. This type of breathing has two important effects on the body. It is itself relaxing compared to emergency mode of breathing of the upper chest, which is an integral part of fight or flight response to a stressful situation. Abdominal type of breathing is a regenerating process, such as when we sleep, digest food, or body is at peace. It is the way babies and children breathe. Abdominal breathing is the most efficient and relaxed way of getting enough air into the lungs. Then we go on to describe the competency, the costochondral and interchondral joints. Thoracic cage consists of 12 ribs on each side. 1 to 12 ribs are connected to the central sternum by means of costal cartilages. Costal cartilage is made up of hyaline cartilage and cartilage is covered by perichondrium. Embryology of the sternum and ribs. Ventral ends of the upper 7 arches, that is ribs, unite on each side to form cartilaginous sternal plate. Sternal plates fuse in the middle and form the rudiment of the sternum. A typical rib is ossified from one primary center. It appears close to the posterior angle or the angle of the shaft of the rib. Ossification proceeds both ventrally and dorsally. At birth, the ventral part of the costal arch remains cartilaginous. Since ossification has to extend a longer distance, hence this portion of the rib development persists as such throughout life to establish elastic recoil of the thoracic wall. Costochondral junctions. Joints of the ribs with their costal cartilages. Every rib makes primary cartilage joint with the costal cartilage. No movement takes place at this joint. The first costal cartilage is continuous with the first rib and the manubrium. Both are usually separated. Both are usually replaced by bone after 25 years. Manubrium and the first rib are fixed to each other and move as one piece. Other costochondral junctions from 2 to 12 may become bone after 25 years. Interchondral joints. Costal cartilages between which the interchondral joints may exist are 5, 6, 7, 8 and 9. Between the adjacent cartilages from 5th to 9th there may exist either of these: synovial joints, ligamentous union without joint cavity, direct cartilaginous union, or connection by means of muscle or loose connective tissue. When a synovial cavity exists in an interchondral joint, a wedge-shaped spur usually extends downwards from the higher cartilage to meet the lower cartilage. Thickest and best marked spur is found between 7th and 8th cartilages. Movements at the interchondral joints. The movements of the interchondral joints are of two kinds. Anteroposterior. The lower cartilage moving forwards and backwards in the upper. The former undergoes a greater amount of rotation than the latter. The anteroposterior diameter of the chest wall is being increased and diminished thereby. A gliding movement in the direction of long axis of the two cartilages, which increases and diminishes the transverse diameter of the chest. So the chief interest, the presence or absence of the synovial joints between the 5th and 6th cartilages, and the tendency for joints to diminish in number with advancing years. Type of breathing in a child at birth is chiefly costal. Diaphragmatic type of breathing becomes accentuated when the child begins to assume upright position. This change is progressive through adult life, and diaphragmatic breathing is more pronounced when calcification of the cartilage limits chest expansion above the age of 50. Epigastric triangle. In the early days of one's life, the presence of interchondral joints assists the thoracic expansion. These joints will do so by facilitating the increase of both anteroposterior and transverse diameters of the lower part of chest. With the advent of abdominal type of breathing, this action is diminished. A change occurs in the size of the epigastric triangle, formed by the lowest rib cartilages articulating with the sternum. Up to 2 years of age, this angle measures more than 75. After 3 years of age, more than 50% of the cases, the angle is less than 75. The narrower the epigastric angle, the greater is the tendency to the diaphragmatic type of breathing. There is a marked preponderance of synovial joints between the 5th and 6th cartilages in the females. An explanation of this is in pregnancy, the type of breathing in the latter months of respiration tends to become more markedly costal. Crus action. The first part of the diaphragm to contract is the crus by means of central tendon and part of the diaphragm attached anteriorly. Direct line of pull of the crus affects the 7th and 8th costal cartilages and tends to pull these cartilages backwards towards the vertebral column. In prolonged supine posture, as in late pregnancy, or paralysis of one phrenic nerve, or in hysteria, asthma, respiration becomes more markedly thoracic. This type of breathing is more marked over the 7th and 8th than elsewhere, and generally more on the right side than on the left. Conclusion. Right side is more richly provided with intercartilage joints. This numerical preponderance is probably due to the presence of liver on the right side, which must be a constant factor preventing the lower ribs from inverting to the full. Intercartilage joints assist in the expansion of the lower thorax, not in the elevation of the upper ribs, and that such expansion is affected by the action of intercostal muscles. Thank you.